Hi everybody, and thanks very much indeed for being asked to come and talk today. What's a fantastic event, and I'm really impressed by what I've seen and heard in terms of what's gone over the day and a half. I've put together a series of slides to just say a little bit about the role that I've taken on and how that links into some of the challenges that I think we're facing over the next 18 months, 2 years, as we make the transition from the current system through into the new system. But I also want to think a little bit about some of the other challenges that are facing us that aren't directly linked to the political changes that we're seeing in the NHS. So some of the societal changes, some of the changes driven for economic reasons. So if I can have the first slide on, please. Thank you. So it's a time of change. I'm not going to rehearse the health bill. I'm not going to talk about the likelihood of there being any amendments and how it's all going to work in the future. You'll be pleased to hear. But there are a couple of points I want to make. That's the white paper that preceded the health bill. And you can't have existed in this country and not seen the furore that's been caused by some aspects of it. But one of the things that I would encourage people to do is to read the health bill, or indeed read the white paper, because it's much more readable, without reading the section entitled Autonomy and Accountability. Because actually, if you read the sections on creating a patient-led NHS, if you read the sections on delivering better health, and if you read the section on the public health prioritisation around prevention, improving the health of the population, then I think you will agree with almost everything that's in it. Where we get into the controversial parts are around the changes to structures that are coming about, so the abolition of PCTs, the abolition of SHAs, the creation of clinical commissioning groups. Actually, much of the rest of this document is an evolution in terms of what we've seen over the last 10 years in particular with the NHS. So, I don't think anybody can argue about empowering patients more, nothing about me without me, which is referred to on several occasions in the white paper, really pushing the concept of patients becoming more and more equal partners in healthcare. There is a story that I tell, and I suppose I need to be a little bit more careful using it in this part of the world, because probably some people in this room will know who I'm referring to, because it does relate to somebody who used to work in a hospital not that far from here. I first took up post as chief exec in 1995, and I inherited a pile of papers that was a disciplinary against the consultant surgeon. And this pile of papers, when I read through it, basically what had happened, a patient had come to see this consultant in 1995, and actually the patient worked at Lancaster University, so I am kind of giving it away now, and said, "Thank you very much for seeing me, doctor. These are my symptoms. This is what I think is wrong with me. I've researched the treatment options, and what I'd like to do today is to talk through with you which of those treatment options you think's best." The consultant told him to F off and threw him out of the clinic. Because what you had was a complete collision between somebody who was educated, informed, aware, knowledgeable about his healthcare in this instance, coming up against a very traditional approach to the delivery of healthcare, somebody who was not used to being challenged, somebody who was going to tell you what was wrong with you, what was going to be done to you, and when it was going to be done. Now, we've moved some way down that line, but I would argue that we've still got some way further to go in terms of eradicating paternalism from the NHS and actually making patients real partners in the delivery of healthcare. So that's the health bill. We're going through a time of tremendous change, and one of the things that we've done as part of the role that I've taken on is to look at the research around what happens when organisational change occurs within the healthcare environment. And the first thing to say is there's very, very little research on this subject. So there may be an opportunity to further explore that, because actually the research around handovers, the research around mergers is very sketchy in the healthcare setting. What there is, though, is some really interesting stuff. So take that one there, the Lessons from CHI Investigations, 2000 to 2003. So it's a document that's 8 years old now. It's incredibly relevant. And if people want to actually look at what's happened in years gone by, when that was around the time in particular we were merging a lot of hospital trusts and we were creating some of the infrastructure that we've had in place for the last 10 years or so, that they found that mergers and organisational change was a significant cause of turbulence, of challenges with quality, of failure to perform for organisations. And if you think the change that we're going through at the moment, if you think of the scale of that, the magnitude of that, to quote David Nicholson, my boss, it's a change so big you can see it from space. It is the biggest transition that the NHS is ever going through. So we have some real risks in terms of how we continue, not just with quality, and this slide relates to quality, but actually with all our agendas, whilst everything's changing around us. So the best practice on this slide, which actually we've identified from clinical handovers, around face-to-face verbal handovers from the incoming team and the outgoing team, a summary of the information that's being handed over to make sure that we get this continuity passed through the system. One of the other things that I'm doing is I'm leading for the NHS on the Mid-Staffordshire inquiry. I arrived in the West Midlands 3 months after the Healthcare Commission report into the goings-on at Mid-Staffordshire Foundation Trust had been produced. And I think I've learnt a phenomenal amount over the last 2.5 years in terms of what went wrong in that hospital, the culture that allowed it to happen, the systems that didn't detect some of the issues that were happening, certainly early enough, and then perhaps even when it was detected, the severity of those issues weren't really realised. But one of the issues that is a part of that is the fact that we went from 3 SHAs to 1 SHA, we went from 3 PCTs to 1 PCT in that part of the world. Finance handover, boxes and boxes of information, very detailed information on all the finances, absolutely immaculate. Quality handover from an SHA to an SHA, mid-staffs, 2006, 6 lines. We are not aware of any particular problems at this hospital. So we need to think about how we actually apply some of the same rigour, some of the same discipline to handing over on quality and other issues that we do to handing over on finance. And one of the pieces of research that I quite like is some research that's actually been done around NASA and their state of heightened alert as they head towards, I suppose it's past tense now, isn't it? They headed towards a shuttle launch, where in the time immediately before the space shuttle is launched, any member of staff working for NASA, literally from somebody who's sweeping the floor, right the way through to the most senior people in the organisation, any one of those people can stop that launch, because they would rather stop the launch than have something go wrong. So if the man sweeping the floor finds a bolt that they don't know where it's come from, he can stop the launch. Now clearly, if you're 3 months before the launch, then there's a different sort of set of systems and processes in place. And I think that's one of the messages that we need to apply to healthcare. And I think at the moment we need to be in a state of heightened alert. So my role, I'm taking responsibility for handover and trying to make sure we've got systems in place for handover during transition, particularly around quality, but also taking some messages elsewhere. I've got a responsibility for identifying the architecture of the new system with regard to quality, so who does what, and particularly who does what when things go wrong. We're looking at creating a single operating model for quality for SHA clusters, which will then link through into PCT clusters. We're looking at what indicators we can actually look at nationally to start. And I use the term good enough because one of the problems you have here is that people will argue for years, literally, about whether or not an indicator is robust enough to be used to measure quality. And that happened with mid-staffs. Well, actually, I don't really care. Let's just have the indicators. Let's start the debate, because it's a way of actually bringing everything together. I mean, if you look at the debate on HSMRs, for example, and we could fill this room with people that would argue for weeks and weeks and weeks about the relative advantages and disadvantages of HSMR and whether or not it's down to coding and whether it's really a measure of patient care. Actually, I don't care. What I've learned from mid-staffs, if you've got high HSMR, you go and have a look. You have the argument about the data, of course, but you go and have a look at the same time. And mid-staffs. So the dissemination of lessons learned from mid-staffs, the NHS response to mid-staffs is another part of the role. But it's not just, as I said earlier, it's not just about reducing risk during transition, it's also about how do we make sure that other aspects of good work that's going on in the NHS aren't lost. We have an awful lot of skills and expertise and knowledge vested in PCTs, in SHAs, all of which will be changing radically over the next 18 months. How do we make sure that the work of the HIACs and the work of people in this room isn't disrupted as a result of organisational change? And I think part of that is to focus on some of the fixed points that we've got in the system, because not everything is changing. NHS trusts aren't changing, Royal Colleges aren't changing, universities aren't changing, National Institute of Clinical Excellence isn't changing. And actually try and use some of those fixed points to move forward. And I genuinely believe that HIACs are an important fixed point as we move forward. Okay, so I said earlier that it's not just about the health bill at the moment, and there are a number of drivers for change. Ever higher expectations of the healthcare system. We expect more. We're in a consumer society, and in the same way as 30 years ago, I would have been, more than that, perhaps 50 years ago, I would have been very happy with the fact that banks were open from 10 o'clock till 3 o'clock, 5 days a week, but actually there's probably half a day closing in there in between, because that's what happened, and that's the way I could access money out of a bank. Well, now we've got internet banking, telephone banking, hole-in-the-wall cash machines, and if you go down to London, banks open 24 hours a day, 6 days a week. The same with supermarkets. 24 hours a day, 6 days a week for a lot of large supermarkets. Why? They've not done it for their own good, they've done it because society's demanded it. And society's demanding the same in health service. And there's a very real debate running at the moment about how we actually start to create a proper 7-day-a-week national health service. And I think that's a real challenge for people. I remember talking to a receptionist in a paediatric outpatient clinic about the challenges of her particular job. And she said the biggest challenge is that all the parents come out wanting to book follow-up appointments for after 4 o'clock in the afternoon, and we've only got an hour in the clinic to do that. Well, isn't there something wrong there? Shouldn't we be starting the clinic at 4 and running it through until 7 instead of doing it the way we've always done it, which is to suit ourselves? Demand driven by ageing. The cost to the NHS of demographic changes is about 1.5% a year on top of inflation. So simply the fact that we're all getting older and we're all living longer costs the NHS 1.5% per annum more. And that's important when I come back to talk about money in a minute. Health and information age, I've already alluded to that, but the digital explosion with regard to healthcare is about to hit us. And this is going to be a really interesting time, and I want the NHS to be at the front of the curve on this, not at the back of the curve. So you can go, Cisco have produced a health booth that actually it looks a bit like a portable toilet. You know those metal sort of oval-shaped toilets? It's like one of those. You go in, you've got a video link to a nurse, you can have your blood pressure taken, you can have your oximetry done, you can have all sorts of remote investigation tests done, and you can have a conversation with a nurse, but you can also be patched through to a doctor if they actually want you to talk to a GP. You can go online now and access online GP service, who if you're prescribed medication, it arrives through your letterbox the following day. You don't actually need to go and pick anything up from anywhere. This is the tip of the iceberg, and at the moment it's being driven by the states. If you look at the impact that sites like Facebook are having for people, particularly with some long-term conditions, there's a particularly interesting site, American site, where you can go on, put your credit card details in, put the details of your long-term condition or conditions, any medication that you're on, and it prints out for you a sheet of A4 with some difficult questions to ask your doctor about contraindications, medical interactions, latest research and evidence relating to your particular condition. What's that going to do for the way in which we all work in the future? One, it's going to take an awful lot longer to see patients, but two, we're still coming to terms, I think, with this situation where I suspect if any person in this room had a rare chronic condition, you would know more about it than your GP. So how do we actually think about that moving forward? How do we recognise this change in dynamics that we're actually going to have? Changing nature of disease, people aren't dying of things they used to. Many cancers have become chronic conditions people are living with rather than dying of. Advancing treatments, again, you know, I think we seem to say this every year, don't we? But if you look to the future at what's coming in terms of some of the new treatments, particularly genetic therapies that are on the horizon, then that is just going to be absolutely phenomenal and very expensive. As the other side of that coin. And the change in health and social care workplaces, hospitals are going to get smaller. If anybody here is from a hospital who thinks their business plan over the next few years is to grow, you have got it wrong. And by grow, I mean number of beds. Yes, it might be grow in terms of providing more integrated care along pathways, providing community services, etc., but anybody who thinks that the hospital is going to get bigger has got it wrong, badly wrong. So, the change isn't just driven by the bill. Money? The NHS over the last 10 years has received somewhere between 6 and 7% above inflation per annum. That's a lot of money. But actually, I talked earlier about 1.5% of additional resource being needed every year simply to keep up with demographic changes. I can add into that approximately 1.5% being spent by the NHS every year simply on technological advances. And I can add on top of that 1.5% being spent by the NHS every year because inflation in the NHS runs about 1.5% higher than the retail price index, which is used as the measure of inflation. So typically, my view is that the NHS needs to receive 4.5% above inflation to stand still. In 2010-11, we had 5.5%. And it was a hard year. It certainly wasn't easy, and it felt really tough getting through that year. Well, we've now got flat real, which basically is inflation and nothing beyond. So that then starts to give us a 4.5% problem year on year before we do anything, because that's the increasing cost that we're seeing. So we're getting flat real from 11-12 through to 14-15. So if you think of that over the 3 or 4 year period, and you say, well, okay, apologies to any accountants or mathematicians in the room, but for the sake of keeping the maths simple, let's say it's 16-17%. 16-17% of the NHS budget is between 15 and 20 billion pounds. You recognise that number? That's the QUIP challenge. So however you approach this, whichever angle you approach it from, you actually end up with a figure that is remarkably consistent in terms of the size of the challenge that we have to face. Interestingly, of that QUIP challenge, £2.5 billion of it is in prescribing costs. A staggering amount of money, phenomenal amount of money going on drugs. So why have we got financial challenge? You may have seen this slide before, but basically the red line at the bottom, this line here, shows the receipts into Treasury, and the top line shows expenditure as a percentage of GDP. So, of course, credit crunch, income to the Treasury falls off a cliff, and as percentage of GDP, spending goes up through the roof. Now, the first thing we've got to do is to get these two lines back together again, because until those two lines are back together, UK PLC isn't in balance, income and expenditure aren't matching. But once you've got those two lines back together, you've got to pay off the bit in the middle, which is the overdraft. And it's huge. These slides are slightly out of date because this was done before some of the latest financial projections. But basically, the NHS is the largest single spending department of state by some way, by some significant margin. But look at the size of these figures. Between the budget in 2008 and the budget in 2009, UK PLC's overdraft grew by more than the entire spend on the NHS in that year. So we're not talking about small sums of money here. We're talking about absolutely phenomenal sums of money, which is why, however we look at this, the NHS cannot be insulated from the financial challenge that we're facing. This is a slide, this is West Midlands data, but this is a slide that really quite surprised me when we look at what we do with our money. Certainly, if I look back over my career, perhaps in the last 5 years or so, I think we've spent a phenomenal amount of time focusing on non-elective pathways of care. Quite right too, because they need improving and they need more work doing on them. But how much do we spend of our entire NHS budget on inpatient emergency care? Answer 10%. That surprised me. I would have said it was higher than that. 10% of the NHS budget spent on inpatient non-elective care. 10% of the NHS budget is spent on inpatient elective care. 11% of the NHS budget is spent on primary care prescribing. I think that is a staggering figure, and it shocked me when I first saw this slide. if you think about how much time and effort we actually focus to, are we getting value for money, are we doing the right thing on primary care prescribing, and so on. That was you, not me. On primary care, was it not? On primary care prescribing, as opposed to inpatient emergency and elective treatment. I went out with an ambulance crew in Birmingham a few weeks ago, and I was completely shocked by the amount of unused medication that we found in people's houses who were being admitted to hospital. Some of it, so for example, an old lady who we went to pick up had, most of it was expired, I have to say, but had probably a year's worth of erythropoietin in a cupboard. Now, it's tens of thousands of pounds. What are we doing? This is money we need to free up to get into innovation, to get into the NHS, to look at other areas. If anybody wants these slides, by the way, I'll very gladly make them available, because I think there's some interesting material on some of this. So, if we've got a financial challenge, how do we go about addressing it? Well, for those of you who remember the late 1980s, early 1990s, this is what we did. We sacked people. 70% of the NHS spend goes on people, so if you're trying to save money, let's sack them. Doesn't work, because we still have to provide service, and actually what happens is the quality goes down. We cut services. Can't afford to do that anymore, so we'll stop doing it. Now, interestingly, we have the R debate, the rationing debate, on a fairly regular basis, and rationing tends to come down to adult bat ears, reversal of vasectomy, tattoo removal, and should we perhaps restrict IVF? Now, I know that debate has moved on since then into procedures of limited or lower clinical value, but it's a very difficult debate to have, and actually I think it's a debate that's always going to be difficult unless the politicians actually get involved in. Of course, the politicians really don't want to go there in terms of the debate about rationing services, but I would argue that cutting services has a negative impact on the health of the population and a very limited impact on actually freeing up resources. Let's stop bringing in new technologies, and we absolutely did that in the 1990s. So the NHS fell way behind much of the rest of the world in terms of availability of CT scanners, MRI scanners. Some of you may remember we had to create some national funds in the early mid-1990s to actually buy a load of MRI scanners to allow us to catch up with the rest of the world. And here's a good one. Let's stop training people. If you're running a hospital, if you're running a budget, if you've got budgetary responsibility, then study leave is a very easy line to cross out. I would actually argue that at times of financial challenge, we need to be investing more in training and development, not less, because we need people to do things differently, and we need to learn from what's going on out there. I would actually argue that somewhere in the NHS in England, we have got every answer that we ever need to all the issues around QIP. The challenge we've got is capturing that information and moving away from the not invented here culture that we have to actually a culture that embraces change. And I'll return to that in a moment. So things that have a neutral impact on health, we can improve efficiency. Of course we should be doing that, and we've still got further we can go. We can improve procurement. Of course we should be doing that, and there's further to go. Rationalise support services. Increase generic prescribing. 16 PCTs in the West Midlands. If the PCT that has the highest rate of generic prescribing for statin was able to be matched in terms of its rate by the PCT that has the lowest rate for generic prescribing of statins, they would save £2 million per year. Now, this isn't some fictitious figure that has been created somewhere that everybody should be aiming at. This is what is actually happening in 2 PCTs. £2 million per year simply by changes in prescribing. Decreased use of drugs, procedure, limited clinical value. I think I've already touched on that. So they have, by and large, a neutral impact on health, but they can have a financial saving. But actually, this is where we need to be, over on this side, which is looking at technological innovation. So investing to do things differently. Early intervention, prevention, self-care, I'll give an example of that in a minute, and quality, including reducing errors. It depends on who you turn to in terms of the literature, but potentially somewhere in the region of 40% of all inpatients in hospitals have had some form of error associated with their healthcare. Some of those have had an impact on them, some of them haven't. But actually, if you look at some of the things that happen here, and if you assume as a rough planning figure that it costs about £400 a day to keep a patient in hospital. If you've got a cohort of patients who are spending 1 or 2 days in hospital because something's gone wrong, because their system hasn't worked or whatever it may be, then it very quickly adds up to a large sum of money. So the challenge for the next few years is how do we face up to not simply the reduction in money, but how do we use this as a burning platform? So how do we bring innovation together with education, together with quality, to actually provide services that are higher quality, more accessible, and do that against the backdrop of having less resource to do it with? The answer to that is QUIP. Now, I just want to pick on a couple of examples here. VTE. First of all, I think it's a scandal for the country that it required a Department of Health directive to tell us to focus on something that kills 25,000 people a year, or was killing 25,000 people a year in this country. Kills 10 times as many people as die of healthcare-acquired, healthcare-associated infection, but wasn't on our radar professionally, and it should have been. But by the way, as well as saving lives, as well as being the right thing to do, if you can halve the number of patients who develop some form of VTE, PE, DVT whilst in hospital, and if you look at what that does in terms of saving in average length of stay and reduction in bed days, it would save a typical hospital, it's changed now, but going back a couple of years, it would save a typical hospital £500,000 a year. That's a lot of money, but it's the right thing for patients. So why haven't we got there sooner? What have been the cultural blocks in the way? 23-hour length of stay hip replacements. Robert Jones and Agnes Hunt, Specialist Orthopaedic Hospital in Shropshire, have been doing this now for about 2 years. They're currently doing a third of all their hip replacements with 23-hour length of stay. Patients think it's fantastic. It's cost effective, it's several £100s cheaper per patient, even net of the additional investment that you actually need to make to provide support to these patients in their own home. Can we get this disseminated? Very difficult. Published evidence takes between 10 and 15 years for a change in practice, an innovative change in practice, to become widespread adopted across the NHS. Actually, that's not true. To become widespread adopted across healthcare, because the figures are exactly the same for the States and for Europe. How do we get that 10 to 15 years down to 10 to 15 months? Because that's what we've got. We know this works. We know patients like it. How do we get it into more common use? Interestingly, if it's a machine that goes bing, the latest piece of kit, then actually people grab that and run with it much more quickly. But if it means I have to change the way in which I do things, it takes much longer. And the evidence suggests that for things like this, what actually happens is as the junior doctors rotate through the unit that are doing it, they learn how to do it, and then when they get a consultant's job, they establish it in their own unit. It's very hard to get existing people to really change their own practice. But I think that's a challenge we have to look at. Productivity, because of time, we won't talk about. Prevention, just a plug for public health people who are in the room. For those of you that think public health interventions, well, okay, they may have some benefit, but it's all 30 years down the line, or whatever it may be. This is a fascinating slide. This is seasonally adjusted admissions to hospitals in England with a diagnosis of acute myocardial infarction. So predominantly people coming in through A&E. There is where the smoking ban in public places was introduced. Look at that line. It falls off a cliff. Now that's not smokers, it can't be smokers because smokers carried on smoking. That's passive smoking. And that's the impact that legislation, pretty drastic legislation, but it actually had on the health of the population. So it's carried on, by the way. I have got this slide, but it carries on at this level. Doesn't go back up again. So first of all, it's the right thing to do for people, but secondly, that is 5,600 admissions to the NHS less per year as a result of a public health intervention to ban smoking in public places. And if you turn that into money, £17 million per annum. Huge sum of money. These are all parts of our solution to QUIP. So, concluding, some people in this room may want to bury their heads in the sand or cross the fingers, whatever it may be, and think, the bill might go away. Well, I'm not going to comment on the bill, because I'm not supposed to. Which never stopped me before. The bill, something is going to happen, because actually, we've gone past the point of no return. We can't go back to what we had, because we're in the stage now where we have PCT clusters, we have SHA clusters, we've lost quite a lot of people from our system, we've got emerging clinical commissioning groups, and I genuinely don't believe that we can turn the clock back and return to what we had. So whatever we end up with in the future, is our job, our responsibility to make it work. We may look at the financial forecast and think, oh, well, it'll be all right, the government has said they're going to protect health. Well, they have protected health to a greater extent than some areas, but we're going to be faced with a huge financial challenge. But the most powerful drivers are the ones that I think I've talked about. The most powerful drivers are public expectations of the NHS and what we are able to deliver on responsiveness of the NHS, of innovation, of thinking about how we turn the NHS into a service that we would recognise in this day of 24 hours a day, 6 days a week, supermarket access, telephone, online banking, etc., etc., etc. And I think we've got to be ambitious. And one of the things that I genuinely believe, if we hadn't had HIECs in place to help with some of this innovation education agenda, then we'd probably now be inventing them. So thank you very much for listening. I hope that's been of some interest, but I really do think that we're in for a fascinating few years, a very challenging few years, but actually with the right mindset, this is the time to make some of these big changes and improve population's health. Thank you.